So we had the question that came in from the audience and around brentuximab and AVD, that combination. I think you addressed it in your discussion, but maybe in a broader sense. I mean, we have the potential now to use it up front, to use it in the relapse pre-transplant setting, post-transplant setting. Where do you think that's all going to settle out? Is it going to be everywhere? Is it going to be here, there? How is that all going to play out? Considering we're going to have studies that to some degree are positive at the back end or positive at the front end, and wouldn't surprise me if somewhere in the middle it's positive. You know, how do we settle all that out? I don't think these patients are going to be on this drug for indefinitely, and clearly a lot of people don't need it because the vast majority of people are cured without brentuximab. So where do you think we're going there?
So that's what happens when you have a single agent that gives you 75% response rate in multiple relapse setting that will be moved and combined in a frontline, in pre-transplant and post-transplant. That's what we're seeing. So I'm not surprised about that. The question is it going to benefit everyone? I don't think it will benefit everyone. And that's going to come down to biomarkers and subset analysis. So we need to look at the subsets who benefited the least in the randomized trial and not offer them this drug, and a subset who benefit the most, and then we offer them this drug.
Okay. So AML seems to be getting more and more complicated. And we're moving from cytogenetics to molecular markers and now targeted drugs. Kind of when you're seeing a newly diagnosed AML patient, how do you kind of tackle that? I know that you're setting off a lot of these studies, but what do people in practice need to know about, and where do you think the future is that are really actionable today?
I mean, I think the basic question of is this patient fit for intensive therapy or are they unfit for intensive therapy remains. Mm-hmm. I think we have appropriate therapies for each of those bins or categories. But we have a lot more choices now, and so that gets a lot trickier. And the real question is, how much data do you need before you pull the trigger and say this is the right therapy? And actually the answer today, I think, is you need a lot more therapy than you used to because you have more options. When it used to be that if you were fit, you got 7 and 3, and if you were unfit, you got hypomethylating agent or low-dose RSC, that was easy. We didn't need to wait for anything to come back. You could tell when the patient walked in the room and by interviewing them. Now we actually need tests back. So for example, for Vyxeos, which is a drug that has a proven benefit in patients with therapy-related leukemia, you can get that off history. But it also has a proven survival benefit in patients with certain karyotypes. So maybe you need to wait for some karyotypic data back. We need flow data to know that Mylotarg is effective, but we also know that Mylotarg is not an effective treatment for patients with high-risk karyotypes, so you want to have both of those. And of course, I mentioned the FLT3 inhibitors, which are effective in patients with FLT3 mutations, but we don't really know what they do in patients who don't have those mutations. They don't have a proven benefit, so you want to have those data. It's gotten a lot more challenging, and really what we've done is we've started to come up with a frontline kind of shotgun approach to sending off a bunch of tests that will be actionable. We want to know if the patients have a core binding factor mutation, which would predict response to Mylotarg. We want to know whether they have a FLT3 mutation. We will ultimately want to know if they have an IDH mutation, though we're not using those drugs frontline. And we want to send all of the next-gen sequencing so that later on we have enough information to do risk stratification. But right now, it's probably going to take several days after seeing a patient who's stable to say, I have enough information to say, here's your best therapy. And that's primarily for older patients where we know waiting a few days probably is not going to impact their outcome. In younger patients, we don't know that we want to wait on them because they can get sick quickly and we want to treat them as aggressively as possible. And there are some data that even say that that might be deleterious to wait too long. So it gets a little bit tricky. I think in my practice, I want to at least get a small amount of genetic data before I say what to treat patients with.
Okay. So quickly, and I think I know the answer, but the question came in myeloma, we have so many active drugs, and it seems like when we combine them in the upfront setting, the toxicities are not overwhelming. Should we be using all of the best drugs up front? Should we be saving them? Should we use 2 drugs first and then 3 drugs later? Should we be moving to 3 and 4 drugs early and then use what we haven't later? What's your kind of sense of where that's going? And I know it's an abstract question at this point, probably. Well, if you look at the data, I think the field has come to a point, if you look in the relapse setting, for example, where all the trials that have been published the past 12 to 24 months show that 3 drug combinations are superior to 2 drugs. So we have already done that for a long time in upfront treatment. Now the question is on the table, would you benefit from adding a 4th drug to
to, for example, an IMiD proteasome inhibitor dexamethasone combination, would you benefit from adding a monoclonal antibody to that? So those studies are in the works right now. There are multiple of those studies looking at different combinations. So I think the proof will be obviously in the pudding. We will have to see if that extra fourth drug really will deliver deeper responses that are sustainable. So that data is not yet there, but the field is moving very fast in that direction. I think with so many drugs available and with the opportunity to monitor deep responses, I think we have kind of passed the old kind of point when we used to hold all the drugs or the few drugs we had back and do one at a time. So we can give a lot of very good drugs up front, and if the disease comes back, we still have very many more to choose from. Mm-hmm. And even if the disease comes back again and again, usually it lasts for quite some time, so you can go back and reuse the ones you use many lines back, and it still can work. So I think that's a new kind of direction of the field.
So the last question, then I'm going to go around and just ask you all to give you each kind of 1 minute on your big other things that you think the audience should get a sense of. But first, Anasa, just one question that came in was about relapsed mantle cell lymphoma, and in a general sense, patients had chemoimmunotherapy initially, they've relapsed. When are you using ibrutinib? When are you using acalabrutinib now? What other things are you thinking about in those patients? Just in a nutshell, any big picture thoughts for the audience?
So the example, if someone, let's say, had a mantle cell lymphoma treated with BR, for example, now progressed, relapsed, what do I do? I tend now to use BTK inhibitors as second line, because the data suggests that the earlier the line you use, the better the benefit. So I used to use ibrutinib before, now we have acalabrutinib. Honestly, I haven't used it yet since it's been approved. I'm looking forward to use it the first time around, but for now, I think ibrutinib is as good as anything else.
Okay.